All right, antihypertensive, probably one of the more clinically relevant aspects of actually the last three topics that we've done are probably the three most clinically relevant topics that you'll do all year. You know, it's things that you will see for the rest of your lives. Now, last month we talked about the more theoretical aspects of the autonomic agents. This is where you see a little bit more of the actual, clinical outcomes. What are we actually doing with those drugs? We talked a lot about, what they could be used for, how they work. Here we're actually going to get into the nitty-gritty of why are we using some of those other drugs. So, you've seen the slide already. We talked about it last week. Beta blockers. Beta blockers are used, for hypertension. We have a whole list of them. We talked about it last week. The non-selective propranolol, the non-selective with alpha-1 activity, labetalol and carvedilol, and then our beta-1 cardioselective drugs like acebutolol, which has, as ISA indicates, intrinsic sympathetic effect. And then we have atenolol, which is mixed. It has some beta-1 but is not completely clean, has some beta-2. And our most important one you will see the most is metoprolol, which is pure beta-1 cardioselective. As we talked about last week, by inhibiting the beta-1 receptors, we're actually able to reduce the blood pressure. Now, it's I didn't write it down because I didn't want to confuse, but the actual way that beta blockers reduce blood pressure, it's not through reducing the heart rate and the contractility of the heart. It's actually by reducing the amount of renin that is excreted by the kidneys. Our RAS system, renin-angiotensin-aldosterone system, we have, I believe it's the juxtamal glomerular cells in the kidney, which are next to the macula densa and the proximal and the distal convoluted tubules coming together. Now, it's actually beta-1 receptors are actually in those juxtaglomerular cells, and they secrete renin. By blocking beta-1, you're actually blocking renin secretion. That's how beta blockers actually reduce blood pressure. It's not because of the effects on the heart. It's been found that it's the reduction in renin release. However, I do not believe they go into that much detail, so it didn't include it. I just, want you guys to remember that beta blockers inhibit beta-1 receptor. The fact that it's working on the kidneys to do all that, it's a little bit more in detail that I don't think that they necessarily are going to test you on, so I haven't included it. Beta blockers are also used for arrhythmias, heart failure, and angina. A lot more than they're actually used for hypertension. And at the end of this little talk on these specific drugs, I'll get in more in detail as to why we use different drugs and which ones we do use when we have a patient who comes in with hypertension. We talked about it last week. Major side effects, major pathophysiologic, or with just major physiologic concepts, bronchospasms and hypoglycemia. By blocking beta-1, we mask the symptoms of hypoglycemia, specifically tachycardia. By blocking beta-2, we actually can possibly cause some bronchoconstriction, and we actually delay recovery from hypoglycemia because we are blocking gluconeogenesis. There are beta-2 receptors on the liver that cause the breakdown of fats and what's the other one? Breakdown of fats and glycogen. Breakdown fats and glycogen, and actually will increase and raise our glucose levels. By blocking beta-2, we actually inhibit that. In addition, as I was talking about at the very, very beginning, when we stop abruptly our beta blocker, we can cause some rebound hypertension, so we do need to slowly titrate it when we do decide to come off it. All right, alpha blockers. So we talked about these as well. By inhibiting the alpha-1 receptors that are found on the blood vessels, we can actually dilate them and cause a little bit of a reduction in blood pressure. They're not really used for that anymore. As you can see by the picture, they're primarily used for BPH and prostate issues in men. Some side effects, we can have some orthostatic hypotension and some reflex tachycardia because if we are dilating the blood vessels, the body's mechanism to compensate for that would be to increase heart rate. Because if you dilate the blood vessels, you're going to have a precipitous drop in blood pressure, so the heart rate needs to kick up to, compensate. And then orthostatic hypertension, the body's ability as you stand up from a seated position to constrict its blood vessels and to shunt blood from your legs back up to your heart and to your brain doesn't work as well. So you can have a little bit of lightheadedness. ACEs and ARBs. So again, going back to our renin, angiotensin, aldosterone system. Now, angiotensin converting enzyme. This is the enzyme that's found in the lung that converts angiotensin 1 into angiotensin 2. What you need to remember is that angiotensin 2 is probably the strongest vasoconstrictor in the body. So if we inhibit the strongest vasoconstrictor in the entire body, we're going to have a little bit of vasodilation. Now, because it works sort of uniformly throughout the body, it's balanced, and we don't really see that orthostatic hypotension that we do with alpha blockers. Now, what we use these drugs for are hypertension and heart failure. It's actually been found to have some mortality benefit in heart failure, so they're actually one of the first-line agents that all patients with heart failure will go on. In addition, they've been also found to be renal protective because of their effects on the efferent artery in the kidney. So they actually, I believe, cause a little bit of constriction of the efferent artery, and by causing some constriction, we'll actually have a little bit of better filtration in the kidney. So they are used for their renal protective effects in chronic kidney disease and diabetes. Now, very, very high yield to know. These cause hyperkalemia, they can cause a cough, and they can cause angioedema. The 3 side effects that you must know for ACE inhibitors. You're going to retain potassium, you're going to have this new dry cough, and there is an interaction that's been linked to the increase in bradykinin that can possibly cause life-threatening angioedema. Now, in addition to inhibiting the creation of angiotensin 2, we were also smart enough to decide, hey, let's just block the angiotensin 2 receptor, and that's what an ARB is. We have our 2 ARBs, losartan and valsartan. So these just block the angiotensin 2 receptor. They're also used for hypertension and heart failure. And similarly, they have the side effects of hyperkalemia. However, there's less cough associated with the ARBs, and then there's less risk of angioedema. So because these are newer drugs, they're a little bit more expensive, and they're really only second line in the sense that we would start with an ACE. The ACE inhibitors were the drugs that were originally studied that had mortality benefit, but because of the cost, we're going to want to fail an ACE inhibitor before we give somebody an ARB. And that's, when deciding whether you put a patient on an ACE or an ARB, you tend to start with an ACE. And if they're having significant coughing issues, or if there's a history of angioedema, then you would consider giving them an ARB instead. Very important to know, they're more tolerable than ACE inhibitors in African Americans. African Americans are more predisposed to the angioedema from ACE inhibitors, and cough, so we'll give them an ARB instead of an ACE inhibitor because of that risk. Very, very 2 important groups of drugs. All right, calcium channel blockers. So 2 very important distinctions between the 2 is that there are 2 different classes, the dihydropyridine class and the 9-dihydropyridine class. The distinction between those 2 is that the dihydropyridine class works primarily on the coronary and peripheral arterial vasodilation, whereas non-dihydropyridines have primarily ionotropic and negative chronotropic effects on the myocardium muscle. So both, they're not 100% specific, so there is some crossover, but the majority of the effects of the dihydropyridines that are on the vasodilation in the coronary and peripheral arteriolar vasculature bed, and the non-dihydropyridine is primarily on the cardiac myocardium. Now, dihydropyridine. These are nifedipine, amlodipine, nicardipine. There's a whole bunch of them, but I believe you only have to know nifedipine. So it's a calcium channel blocker. It is working on the voltage-gated calcium channels in the vascular smooth muscle. This eventually leads to coronary and peripheral arterial vasodilation. These are used for hypertension, as we've talked about before. Increase in the vasodilation can reduce blood pressure. And it's also used for angina, in the sense that if we vasodilate the coronary arteries, we can actually increase the supply on the heart and actually relieve some of our anginal pains because we're able to provide more oxygen to the blood vessels. In addition, some of the side effects, we've talked about this before. If we vasodilate peripherally, we can cause some reflex tachycardia. There's some headache and flushing involved. In addition, another big side effect is actually peripheral edema. For whatever reason, we've talked about peripheral vasodilation before without having this side effect, but for some reason, calcium channel blockers are a little bit more, patients are a little bit more predisposed to developing peripheral edema. So you want to think about calcium channel blockers and peripheral edema. Okay, non-dihydropyridine. So these are exclusively verapamil and diltiazem. So as I said before, these are inhibiting the voltage-gated calcium channels, primarily in the myocardium. So we mostly have a negative ionotropic and chronotropic, less beating and less strength of contraction, similar to a beta blocker. There is some vasodilation, but it is not, I wouldn't say clinically significant. Biggest thing, these can be used for as I said before, angina and hypertension, but now because we have negative ionotropic and chronotropic effects, we can also use these for arrhythmias. So patients coming in with supraventricular arrhythmias, with AFib, can actually get verapamil or diltiazem or a beta blocker. So it's sort of another tool in our toolbox. Side effects, obviously, if we have negative ionotropic effects, we can have some bradycardia. And as we said before, the calcium channel blockers are at, predispose you to getting peripheral edema. Tricky little one. It can't really explain why, but for whatever reason, verapamil is related to constipation. It can cause constipation. It might come up. It's one of those sort of weird side effects that you just have to know verapamil can cause constipation. All right. Now, last week we talked about a whole bunch of different drugs. So these are some of the more adjunctive agents, historical agents that we can sort of talk about. So reserpine, we talked about this last week. So what we're doing here is we're depleting the amount of epinephrine and norepinephrine in the synaptic terminal. So not a lot of it is released. So it's sort of reducing our adrenergic tone, and it can be used for hypertension. It was actually one of the first drugs discovered for hypertension. However, it had a whole host of horrible side effects like depression, anxiety, and psychosis, so it's not used anymore. We talked last week about clonidine. Clonidine is an alpha-2 agonist, and we remember that on the presynaptic nerve terminal is our alpha-2 receptor, and when we activate it, we're actually reducing our amount of norepinephrine and epinephrine released. The alpha-2 receptor is like a regulation receptor. We're releasing norepinephrine in our synaptic nerve terminal. So much of it is there that it begins to spill out and hits the peripheral part of the synaptic cleft, and that's where our alpha-2 agonist is. And by hitting it, we're actually going to cause a reduction. So these are used for hypertension. However, as I talked about before, clonidine comes in a transdermal patch. And so when it is, when you forget to take this medication or place it on you as a patch, you can have rebound hypertension when it's discontinued. So that sort of answers our question from before. Clonidine is a transdermal patch, and it can cause some rebound hypertension. Methyl-dopa was another Alpha-2 agonist we talked about before. This one is primarily used in pregnant women, and there is that nasty side effect of a lupus-like syndrome in those who take it. Nitrates. So nitrates vasodilate peripheral veins and arteries. So nitrates are dilating veins and arteries. They can be used for angina and for pain relief in acute myocardial infarction. So for angina, what it's actually doing is it's dropping your preload. So you're vasodilating your veins and your venous system, so not as much blood is actually able to get back to the heart. So it's that Frank-Starling law. If there isn't that much blood in your heart doesn't have to contract as hard. And by that mechanism, your heart doesn't have to work as hard. And so therefore you're decreasing its, work rate, and that's how you actually are reducing your anginal pains. Big side effect. Nitroglycerin specifically you can develop a tolerance to it. That's why you tend to not give it 24/7 around the clock. So we have a drug isosorbide dinitrate, which is just a combination of different nitroglycerin molecules, and you can take it in the morning and the afternoon, but you don't take it at night. You need it's called a nitrate holiday to make sure that you don't become tolerant to the effects. Big side effects: headache and dizziness. These can, you'll give this to a patient and they'll immediately say, I feel like I have a little bit of a headache. Very common. Nitroprusside is our IV formulation nitrate that is given for patients with hypertensive emergency, something we will talk about in the next few slides. Big side effect, I believe it is coupled with cyanide. It is, I think, a cyanide molecule that has been attached to 6 nitric oxides. So the nitric oxides will uncouple and be used to create arteriolar and venous vasodilation, and then you'll have your cyanide toxicity, your cyanide molecule. So you'll typically see this in patients who have renal dysfunction. So you'll see a patient, they'll have some renal function issues. You'll give them nitroprusside because they have hypertensive emergency, and bada bing, bada boom, now you have cyanide toxicity. Last few agents, hydralazine. Hydralazine has a bunch of A's in its name, so therefore you want to think of it as your arteriolar only vasodilator. Similar to methyldopa, it has an SLE lupus-like syndrome that can occur, and interestingly, it's coupled with isosorbide dinitrate. And so this drug combination was studied for patients with hypertension, and it was actually found to be ineffective except for African Americans. So say more of a trivia question than it is a board question, but Bidil, the combination of isosorbide dinitrate and hydralazine, is actually only approved for African American patients with hypertension because it only showed benefit in the clinical trials in that patient group. Finally, I believe we talked about that last week, midazolam. Midazolam was another, I believe it's an alpha-1, alpha-acting agent, and they originally looked at it for hypertension. However, they found that it caused hair growth. So we now call it Rogaine, which I'm sure you've heard of, and it is used only in that sense. All right, so I have a couple big picture slides to help you understand. Because last week we were talking about this with antibiotics. And, some of you were, asking questions like when do you use an antibiotic versus another? Can't really get into that when I'm just introducing antibiotics because it's very dependent on the bug that you're using. However, when we're talking about hypertension, it's a little bit easier to get into guidelines because there are sets of guidelines that talk about what we use. So for hypertension, just a little bit of a big picture. You want to call it 2 or more visits with a blood pressure reading of greater than 140/90. Now, the 2 or more visits is because of the whole white coat hypertension. We're trying to make sure that it actually is an elevated blood pressure and you weren't maybe just stressed or drank a lot of coffee that morning. Now, treatment is a little tricky. The JNC7 guidelines came out many years ago. More recently, within the past 5 years, JNC8 guidelines came out, but there was a lot of discrepancy as to whether we're really going to follow them. And then there's American Heart Association is coming out with their guidelines, but they haven't been printed yet, so there's a little bit of discrepancy. I'm going to give you the major highlights. For non-African Americans, your first line agent is going to be your thiazide diuretic, like hydrochlorothiazide. Your second line is going to be an ACE or an ARB or a calcium channel blocker. Or if there is a compelling indication, we would start with that, and that's something I will explain on the next slide. If you're an African American, the first line agent is actually going to be a calcium channel blocker. You can also use a thiazide. Second line would be your ACE or an ARB, because we talked about before the higher likelihood of having the side effects of the cough and the higher likelihood of angioedema in the African American population with an ACE or an ARB. Regardless, if there's a compelling indication, we would start with that medication first. Finally, in patients with chronic kidney disease, we will start with an ACE or an ARB because of their effect on the afferent artery in the kidney and having renal protective effects. Second line would then be a thiazide or a calcium channel blocker. Our goal, it's generally, I want you to think 120/80. In JNC7, I believe for a diabetic, they wanted you to keep the blood pressure at a little bit higher, at 130/8, 130/90. In JNC8, we talk about patients older than 60 or 65. You can be a little bit less at 150/90. There's a whole host of debate on blood pressure goals. And then I believe it was 2 years ago, the SPRINT trial came out, and everybody needs to be below 120/80 at all times at whatever cost. There's a lot of debate about goals. I wouldn't worry so much about that. I'd worry that generally you're going to shoot for 120/80 for most of your patients. And as you get into the nuances of different things and different trials, there's some variability. But it's actually extremely hotly contested right now at what our true blood pressure goals should be. All right, I said before, compelling indications. Well, for certain patient populations, a specific drug may be a little bit more beneficial. And this is specifically from our JNC8 guidelines. We sort of got rid of compelling indications, even though they still exist in our updated JNC8. So, for example, as I said before, African American, sort of a compelling indication would be starting with a dihydropyridine calcium channel blocker or a thiazide because of some of the side effects that they can get from ACEs or ARBs. Diabetics. For a diabetic, we sort of want to start with an ACE inhibitor because of the renal protective effect preventing diabetic nephropathy. Arrhythmias. Arrhythmias are a little bit tricky. In that sense, it's more so about what we wouldn't want to give to somebody with an arrhythmia or angina. So with an arrhythmia, we wouldn't want to give somebody a hydralazine or an alpha-1 blocker or a dihydropyridine calcium channel blocker because we could cause some reflex tachycardia. For your BPH, we talked about this before, alpha blockers can actually treat BPH and hypertension, therefore it would be a compelling indication. Finally, if you have a pregnant woman, we're going to give alpha-methyl-dopa. You can also use labetalol and nifedipine, but the answer on the test is going to be alpha-methyl-dopa. Finally, never give a pregnant woman an ACE or an ARB. They are teratogenic. Now, I also have a little chart over here. We'll get into this more when we talk about heart failure, and we'll talk about MIs and coronary artery disease later in this specific lecture. But a patient with a heart failure, they're going to be on a diuretic, a beta blocker, and they're going to need to have an ACE or an ARB. So sort of explaining that, certain disease states are going to warrant certain drugs regardless of what their blood pressure is. Patients with MIs all have to be placed on a beta blocker a beta blocker and an ACE inhibitor. Coronary artery disease, I'm going to probably have the patient on a diuretic if they haven't already had an MI or their cardiac output is not as good. They're probably going to have to be on a loop diuretic and possibly a thiazide for their blood pressure. Beta blockers to reduce cardiac remodeling and reduce mortality risk, and ACE inhibitor as well. So you can see there's a lot of different indications here. Oh, and as I talked about many times, we don't want to give a beta blocker to a diabetic. All right, and so of course before we start with drug therapy, there's always the before we give you a drug, we're going to try some lifestyle modifications. So this is sort of just an FYI slide to show that, there are certain things that we can do to, possibly reduce our blood pressure. And so when the doctor says, you want to start your DASH diet, if somebody were to follow that perfectly, here's the approximate amount of millimeters of mercury you could actually reduce your blood pressure when you recommend these different things in a patient's lifestyle. Finally, we have hypertensive urgency and emergency, two very important topics. So, patients may be hypertensive for a while, but what happens when they're in your office and they come in and, their blood pressure is through the roof? What do we do then? So those two terms have been defined as hypertensive urgency and emergency. Hypertensive urgency is when you have a blood pressure that's systolic greater than 180 and diastolic greater than 110. So you technically, if your blood pressure is 150 over 120, you would technically fit hypertensive urgency because of the diastolic. They are, you can have both or you can have one or the other and you fit the category. Very important, no end organ damage. So that is your definition of urgency. Emergency is above with the addition of end organ damage. End organ damage being hypertensive encephalopathy. So they're confused, they're altered. Retinal hemorrhages, papilledema, you can see that when you do your eye exam. Or some acute or subacute kidney injury. They're anuric, they're oliguric, things like that. There are a few more, but it's an emergency or it becomes hypertensive emergency when they come in and they're not asymptomatic. There is something else going on. They're altered. They're having these issues that you can see in their eyes. They're having a stroke. They're having a heart attack. So what do we do? How do we treat? We treat by giving intravenous drugs, not oral drugs. This is an emergency or an urgency. We need to give something a little bit stronger. Different drugs that we can give, we talked about before, nitrates and nitroprusside. And I want to give the caveat with nitroglycerin, you tend to give that as a paste. So I did actually see this. You have a patient in their bed and their blood pressure is in the 200s. You can actually take the nitroglycerin, it comes in a paste, and you can actually put it on their chest and just put a little 4x4 over it, and that will slowly absorb. Nitroprusside tends to be a very big drug that they'll use quite a bit. It's very expensive, so in hospitals with lower economic resources, you may not see it as much. You can use phenoldiprem, which is a dopamine agonist, beta blockers that are IV, like labetalol or esmolol. You can use enalaprilat, which is an IV ACE inhibitor, or hydralazine. I would say for your board questions, you're probably going to see nitroprusside the most used for hypertensive urgency. That tends to be the drug of choice on the boards. Finally, very important, your goal of treatment is to reduce your mean arterial pressure by 10 to 20% in the first hour you see the patient, and then about another 5 to 15 over the next 23 hours. You do not want to rapidly lower the blood pressure, because by that sense, if your body becomes accustomed to the high pressures. So if you rapidly lower the blood pressure, you could actually end up causing the patient to have a stroke or an MI, but becoming rapidly hypertensive. So very, very important point. You see this patient, you sort of start slow, go slow. Reduce that pressure by about 10 to 20% in the first hour. The mean arterial pressure, not the actual systolic or diastolic, the mean arterial pressure. And over time, the urgency patient could actually be treated in the outpatient setting. So if you have a patient in your office and they're in hypertensive urgency, you may actually be able to give them some medication and actually put them in a room with a quiet office room, turn off the lights, and see if you're able to improve their blood pressure. The emergency patient is an emergency, as it is stated in the name, and that patient needs to be admitted to the hospital and monitored.